Good morning. I hope you were all able to get here on time before the traffic jam started. I know I was able to. So my name is Mariana Tiabet, and I'm the lead of Merck for Mothers. How many of you were at our event last year? So a couple of folks. And how many of you have watched Groundhog Day? Okay. So this is not going to be another Groundhog Day. What we want to do here is actually hold ourselves accountable from the conversation that we had last year around how to bring the promise of innovating financing to help us meet our SDG goals, and most specifically, our goals for maternal and child health. We need to bring all of our resources, all of our ingenuity, capabilities, and commitment to the task. And this panel that we are hosting here today will be about those folks who are leading on these efforts so that we can actually learn from the progress they have made, but even more importantly, identify challenges and obstacles still to be broken down, and also identify opportunities for collaboration. And I think it's fitting that we have the best minds here because Merck for Mothers was created to bring the best of Merck to helping create a world where no woman has to die giving life. And yesterday, I was on another panel and talked about Salome Karwa. I don't know how many of you know her, but she was a Time Person of the Year in 2014. She was an Ebola fighter. She survived Ebola. And she gave back to her community, gave back to her health system, and helped stem that epidemic. But unfortunately, even after her service to her health system and to her society, when she was pregnant a couple of years later, she gave birth in a facility, went back to her community, and died a couple of days after giving birth. And so neither her community nor her health system was able to save her. And so I do want to remind all of us why we're here, where we're here today. We're here to make sure that all of our combined efforts at the end of the day are creating value and creating what we care about and what we value, which is saving and improving lives. And there are many ways to create this value. We can capture value that already exists in the system, much of it from local private entrepreneurs and local private providers. We can create value through innovation, including innovation in financing mechanisms. And we can bring new value to the table by focusing on these innovative financing mechanisms that we are trying to create so that they will result in not just financial impact, which we know we need because we need to have regenerative and renewable and sustainable sources of investment, but also the social impact around saving and improving lives. So I'm really excited to be here today, part of our partnership with Devex, to bring the best minds and the efforts that all of you are taking to figure out how we can close that $33 billion a year gap to meet the maternal child health targets for the SDGs. And so without further ado, I will ask Raj to come and introduce the day and introduce the panelists, and for all of us to remember that this is not about a project. This should not be another Groundhog Day, but this really is a marker, a milestone in our pathway to progress. So thank you so much for joining us.
There we go. Good morning. Good morning, everyone. I'm Raj Kumar. I'm the President and Editor-in-Chief of Devex. Delighted to add my welcome to you this morning. It's great to be a partner with Marianne. We've taken the show on the road in a few places, And the thing about Marianne is she never loses sight of the ultimate person we're trying to support. And that is very easy to do, especially at weeks like this, in fancy ballrooms and in high-level policy discussions. It is easy to forget that half the world does not have access to the very basic essential medicines we all take for granted in many of the places where we live. And when I come to UNGA, as I've been coming for many, many years, occasionally you can think, why do we do this again? Why do we stand in these security lines? And why do we put up with these days that start so early and end so late? Well, actually, things happen at the UN General Assembly. They may not get signed or decided, but actually momentum gets built here. And it ends up affecting millions of lives around the world. And one of the things that happened yesterday was this UHC declaration, which you've maybe read about in the pages of Devex, and we've all been talking about UHC for a long time, so it might feel like, well, of course, the UHC declaration happened. There was a summit. We expected this. But it wasn't inevitable. It wasn't inevitable. It was because of many of the leaders that are in this room and people like yourselves who have pushed for years to say, actually, there's this radical agenda out there that even though we know the realities of the inequality in the world today, we're going to put a target that says every human being deserves access to health care, that it better be high quality, and it shouldn't bankrupt them to get it. And that's a pretty radical, transformative idea that is now so commonly known, we just know the acronym. There's now been a declaration signed by many countries. So we're in a different position because of a lot of the advocacy and leadership that's happened here. And I think that's really important to mark. And that's the reason why we at Devex decided at this UN General Assembly to actually host a pavilion, the UHC pavilion, on this theme with many events throughout the day, many of them here in person, but a lot happening online too. And I want to welcome those of you who are joining us on the live stream and watching this video from all over the world, because really this is an effort of changing the mindset around what is UHC and what is possible. But exactly as Marianne says, we don't want to just repeat over and over where we are. We do want to push for that progress. So I want to call your attention to an important element of the title of this session, which is the 2.0. This is Funding the Future 2.0. We really want it to be about 2.0. I just wrote a book called The Business of Changing the World, and it's a very optimistic book where I talk about how this is an industry that's transforming, and there's a real opportunity to transform it in the direction that will benefit millions of people's lives around the world. But that's not necessarily going to be inevitable either, just like the UHC declaration. And actually, there are few examples of the financial innovation that we often talk about, of the development impact bonds, of the blended finance. The numbers are still relatively low. And we're going to be hearing from leaders who are at the edge of this and pushing it. But one of the reasons we want to be here today is to say, actually, we can do a lot more. And how do we get there? So one term that I often hear in these kinds of sessions is actually a Shakespearean term. It's hundreds of years old. It's strange bedfellows. You all know this term. And I'm hoping that we can help to retire that term today from the UHC conversation, because actually there's nothing strange about the bedfellows we need if we're going to try to get to UHC. We need every element of the broader global health community. There's just no other way to get there. And I think we're going to get into that in discussion today that hopefully will drive that point home. So welcome to all of you online and in person to what I think is a really important day. If you're looking for more content around what is UHC and what's happening, we have an entire website we built called Healthy Access that has videos and interviews with patients and providers all over the world that talks to health experts from many institutions and agencies. We're really trying to draw a very wide tent around this issue. That's the only way to drive it forward. And if you're tweeting, it's UHC Pavilion, hashtag UHC Pavilion. So please, you got the spelling here. I'm not great at spelling. It's one L. So with that, I just want to welcome our panelists to please join us on stage. Please. No particular assigned seating. Take the seat that you're most comfortable with. Thank you. So we have here to my left Monique Vletter, who's the practice manager at the Global Financing Facility, GFF, and one of our co-hosts for this event today. Thank you very much for doing that and for being here. We have Siddharth Chatterjee, who is the UN resident coordinator in Kenya, who has been a frequent guest on Devex panels. So some of you who are regular attendees know Sid. Thank you for being here as well. We have Agboje Imokwede, who is the co-chair of the board of directors at GBC Health, a prominent business leader in Nigeria. Thank you for being here as well. and Catherine Kaufman, who is the Managing Director for Global Women's Issues at OPIC, which we can still call OPIC, at least for a little while longer. We'll get into that. So I want to start off with this 2.0 issue and the framing I used at the beginning, which is to ask you where you think we actually are in this trajectory. I mean, Monique, maybe I can start with you because GFF is how many years old now?
5 years old.
5 years old. So we're at kind of a point of maturity. You've raised how much money so far?
2 billion for the trust fund, and in a catalytic way, about 7 times that amount.
Right, because it gets leveraged up. So it's a significant point that GFF is at, but how do you look at the moment we're in when it comes to these innovative partnerships that maybe hopefully are no longer innovative or soon will no longer be innovative, but partnerships that include private sector and new financing opportunities like GFF? Where do you think we are?
Right, and thank you for the opportunity. Thanks for co-hosting this at work and Devex. So maybe just for those that don't know what GFF is, so GFF was created really to give a big push to the Women and Children's and Adolescents Health Agenda in 2015 around the development finance agenda, looking at various sources of financing. So not just donor financing, but how can we leverage private financing? How can we work with government to raise domestic funding for this important agenda? It's very much linked to the UHC agenda because at the core of it, we work with countries, under countries' leadership, to set clear priorities on national level and bring in those different sources of financing to then finance that agenda. And we push that through a comprehensive package of services on country level. We engage in various ways with private sector funding sources. Through, for example, on country level, through the implementation that private sector, so contracting of private sector service delivery. We do it by using the capacity of the private sector to bring more efficiency, for example, to the supply chain or to lab resources or to ambulance resources. But then on global level, we look at ways to leverage finance, private finance on very large scale. And GFF is hosted by the World Bank. We work with the Treasury. And we issued a sustainable development bond for $2 billion over a 6-month period to really tap into that interest that exists in private investors that want to achieve social impact goals, and bringing in new investors that have purchased this sustainable development bond from the World Bank to really raise this kind of resources, $2 billion for this sustainable development bond.
Which is maybe just worth saying, $2 billion is a lot in one sense, but if you look at, for example, green bonds, those are maybe in the hundreds of billions now. So we're still in the relatively early phases of being able to raise large amounts of private capital for health and development impacts.
Absolutely. I mean, we thought for the 6 months, the $2 billion was a pretty nice achievement, but we do know that we have a long way to go. Absolutely. And then we need to make sure that that funding actually gets to the right people when it comes to Marianne's introduction, right? How does that funding then come to the people that are most marginalized, that really need those services? And how do we ensure that we use the GFF grant funding to make the larger private sector funding really have an impact on poor people? And so that's really where the catalytic function of the GFF comes in. And
it's too early to say if that's happening yet, or you think it is? Where do you think we are?
It's happening. I mean, we have examples in Vietnam, in Guatemala, where, as part of the discussions with the government, we say that they're bringing out, they're using the funding that has been raised through the Sustainable Development Bonds, and then we bring in some grant money to make sure that that funding then is really targeted to those most marginalized. You have populations in Vietnam, for example, that have lower health outcomes than some populations in Africa, and similarly for Guatemala. And so what are the issues in Guatemala? Nutrition. Who are the people that we need to reach? And then how do we use those financing tools to really target those people?
Thank you for that. Maybe I can bring you to the discussion to get your take. You're in a very large economy, a very big business sector. And of course, you're looking across Africa, not just in Nigeria, but what do you see the growing role of the private sector in this conversation? Where does the private sector fit in today?
Can you hear me? The private sector fits in everywhere. To start with, I think we need to contextualize healthcare in Africa properly. So 50% of expenditure is out of pocket. And imagine that when you look at the per capita income and the poverty levels, it's striking that people are spending 50% of what they don't have on healthcare. Okay, and it then points to the quality of what a poor person can afford to get if they are their own healthcare provider. And then 50% of healthcare is actually provided by the private sector, not by government, okay? But what we do know is that healthcare, when you get it, is often inadequate and could be very much improved across Africa. Now, the financing issue is a bit different in Africa. In the first place, healthy economies tend to breed healthy people, okay? And unhealthy economies, as you can imagine, lead to unhealthy people. So there is a huge funding gap, as far as Africa is concerned. So the first thing is that how do you fill that gap, okay? Our governments certainly, don't have the capacity to fill the gap, and so the private sector has to come in and do some heavy lifting. Now, the problem, however, is if I think from the perspective of a banker, okay, and if I look at loans to the health sector across Africa, okay, it's ridiculously low. Ridiculously low. It doesn't register. And you know why? It's because people in finance don't understand the issues of health. They are very well removed from health. So I think the first thing that we need to do for Africa is to get this type of strange bedfellows in the room. Get the finance people with the government people, with the practitioners into the room and talk about it and bring proximity to it. I mean, I remember, working on a malaria bond, and I remember some super investment bankers in the room, okay, and they were structuring and working and dicing. And I asked them, what do you really know about malaria? And they said, do we really need to know anything about malaria? I mean, it's an instrument that we're putting together. And then it leads to so we do raise the financing, but then it doesn't work. And I think that's the crux of the matter. Beyond raising financing, for me, my goal with GBC Health and ABC Health and on the ground is to make sure that it works, okay? There is a result that is tangible and measurable.
What do you think about the role, though, of domestic resource mobilization, which is our fancy terminology in this community for basically raising tax revenue to fund these things at the domestic level? Because in the end, if you have a malaria bond, someone has to pay it, right? And in the end, that's probably going to be government. So where does that fit into the conversation you're having? You rightly made the point, 50% across Africa is out-of-pocket expenses. In some countries, it's far more than that. So where do you see domestic resource mobilization coming into this picture?
From many angles. The beginning of, I think, solving Africa's health challenge is health insurance, okay? And the pooling effect that comes with health insurance and the power of health insurance, So the 1.2 billion Africans contributing small sums, okay, to cater for the 10% of us that fall ill is significant, And but health insurance doesn't work in Africa generally, okay? And that's largely more a function of government policy. So I think health insurance is one way of addressing the gap. The other thing is that if you take Nigeria, for example, right? Nigeria has officially about 20-something billion dollars of remittances, okay, that come into diaspora remittances that come into country, okay? And my anecdotal evidence seems to point that 20% of this is health-related spending. Yeah, it's me sending money because my aunt is ill or, and so on, okay? And again, this is huge, So I think the issue really is we have a lot of activity, but it's very badly coordinated. And that's why collaborations, coalitions, and so on are absolutely necessary.
Yeah, it sounds like, to use the economics term, this would be a market failure, right? The money is actually in the system. It's being spent. It might include wealthy Nigerians flying, to the U.S. for treatment, right? And the total cost of that because they're not seeing the quality they want in their own country. If you add up all that money, there actually is a market, in a sense. And those investment bankers that you talked about that don't know anything about malaria, if they saw the dollar signs, if they saw that, well, there is a market we can capture, it might change the attitude. I wonder, Catherine, turning to you from OPIC, because you're helping to support private businesses that are trying to get into markets like health in developing countries. What do you see happening in the health markets where you focus?
I couldn't be following more comments. I feel that you're directing them toward me as the strange bedfellow on this stage, who is a finance person who knows nothing about health. I find myself on this stage because I sat on a panel with Marianne and actually learned the term maternal health a year ago. I mean, this is embarrassingly true. And just because of that experience and saying, well, I have money, how can my dollars, because she's obviously so inspiring, how can my dollars be put toward better maternal health outcomes? And it was exactly as described. As a finance person, I said, well, we'll just put together a development impact bond and we'll pay for healthy births. And we spent 6 months pursuing the wrong financing structure. But what we did have was radical collaboration between people that had a common mission and different tools to bring to bear. So we brought together development finance, which I represent, Merck for Mothers, which understands maternal health and on-the-ground needs, USAID, which has that beautiful, beautiful, we think of it as free money, raspberry money, technical assistance, grant money, and Credit Suisse, which, you know, our goal is to mobilize additional private capital toward these outcomes. And bringing those partners in a room that don't understand exactly what the other one does, but knows we all need to get to that sustainable outcome at scale. So we're really not interested in the $5 million development outcome bond. We've got to put at least $50 million behind this to see where we can reach scale and what financing structures work. So I think that collaboration with different types of partners is starting to happen more and more. I think it's because blended finance is becoming a more accepted tool. But I don't think we're there yet in terms of knowing exactly what the right structures are. We're learning a lot of lessons.
I think maybe, Sid, it's a good moment to bring you in because you actually have built a structure, right? This SDG partnership platform in Kenya that you were instrumental in creating. And that has launched partnerships that include an innovative finance component in the health space. Tell us about that, and what did you encounter in doing that? Is it replicable? Is it just a specific set of circumstances in Kenya, or can we bring this elsewhere?
Well, thank you. The reason that we created this partnership was essentially to safeguard the sacredness of the primacy of sexual reproductive health and rights, and that was really focused on the dire situation of maternal mortality in Kenya. So when I came to Kenya in 2014 as the head of the UN Population Fund, we were looking at a maternal mortality ratio of about 488 deaths per 100,000 live births. The MDG 5 target was less than 170 deaths per 100,000 live births. Quite clearly, countries like Ethiopia and Tanzania and Rwanda were well ahead of the curve, you know, and it was fascinating that some of the innovative stuff that they started to do, but somehow, as I said, overall, we tend to get very complacent about the importance of sexual reproductive health and rights, and I think that is what underpins universal health coverage. Anywhere in the world, whether you look at post-Second World War Europe or you look at the Asian tigers, what they did get right was SRHR. And what they did ensure was they managed to get UHC in place. And they did that through resource mobilization in country and not being over-reliant on loans and bonds to be able to do that. And that's where the specifics now come in. The nature of the public-private partnership platform, actually where I give huge amount of credit to Merck and Philips and GlaxoSmithKline and Safaricom and Huawei and Kenya Healthcare Federation, was it became a little ecosystem that came together in 2015. And with about $15 million, we went to 6 of the hardest to reach counties. And these are counties which have seen the scourge of cross-border terror and localized conflict and with the worst maternal health indicators. In fact, there's a county called Mandera, which has a maternal mortality ratio of 3,795 deaths per 100,000 live births. And just to put it into context, wartime Sierra Leone was 2,000 deaths per 100,000 live births. Now, that was where the difference was. And just this coalition was able to bring down those figures by 1/3 in a matter of 3 years. Try that in India or Nigeria, it would take 10 to 15 years. So what we found was how important it is to have big data, technology, and innovation in lockstep with each other to be able to start leapfrogging it. So the purpose of this platform was precisely to do that. Bring the companies in, bring the political capital in, make sure that the right public policies are in place and weave the right partnerships. And nothing is strange about it because Just for an investment point of view, healthcare business in Africa by 2030 is going to be $300 billion worth. What is failing in Africa is the preventative side. And for example, in Kenya alone, 1 million Kenyans get into poverty each year because of an out-of-pocket health shock. And we want to change that. And that ecosystem will change when you look at a new arrangement where the private sector actually sees a benefit of that investment in the preventative space rather than the curative space.
Yeah, you make me think of what I was saying before about healthy economies and healthy populations being two sides of the same coin.
Precisely.
That argument hasn't yet fully won over the finance minister, the sort of typical, prototypical finance minister we often talk about in sessions like these. There still isn't, in many of the biggest countries you talk about, India, I think their current percentage of GDP that goes to health is 1%.
That's right.
Right, so many of the countries you talk about, that domestic resource mobilization number is very, very low. But I do want to push back on you slightly on this question where you say many of the success story countries did not use loans or bonds. Because now if you look at the gap in the world, right, the successful, healthy countries in the world that have good statistics, they're spending several $1,000s per year per patient. And in the countries we're talking about, the numbers can be $50 a year, $100 a year. I mean, the gaps are so dramatic. And this is an era of NCDs as well as things like maternal mortality. So don't we need to see a much larger inflow of cap from all sides to make that work?
I would say governments need to make space for more foreign direct investment. Singapore is a good model. Mandatory health insurance. That means every time an employee is working, there's a certain amount of his salary which is put behind into a health insurance system. What it did was there was enough of money in the market to play around with to deal with catastrophic health shocks. But what they did invest, which is much cheaper, is on the preventative side. So just imagine 100% immunization coverage, prevention of waterborne and vector-borne diseases, prevention of, improving maternal health outcomes, prevention of NCDs. Just 2 NCDs hangs like the sword of the Damocles over the world, and, diabetes and hypertension. And the journey of nutrition, and I think this has been very poorly understood, is we've generally dealt with nutrition at the time of birth of a child, and then we look at the first 1,000 days of life. We've ignored nutrition from the point of conception, where the mother becomes anemic, repeated pregnancies, and you're already starting stunting inside the womb. So I think, if we were to just address the preventative side, Raj, we can reshape the UHC arena into actually ensuring that we leapfrog it so quickly that, we don't need to worry about a lot of these outcomes that we are struggling with today.
It's one of the benefits, I think, of the UHC framing at a global level is that we get a little bit away from the vertical fighting of this disease category versus that one, because in the end, this is all very much connected. There are several threads there I want to pick up on, but I want to come back to you, Monique, because you may have things you want to react to there. But in particular, I'm interested to know, are we at the point yet where some of this is productized? And listening to Catherine talking about going down the road of a development impact bond, realizing that's not the right thing, getting others together, listening to Sid talk about creating this organic ecosystem in Kenya. Why are we not yet at the point where the same way you can look at your 401k and pick an investment, that there are just some more clear products out there for investors to look at?
Yeah. And so maybe as an introduction to that, and I've been told never to answer a question directly. So,
Good World Bank training.
Exactly. I want to bring it back to really where the core is, and that's at the country level, right? And so if we think about a virtuous circle in which, we imagine a government that is clear about their priorities in consultation with their civil society and their private sector, and is then able to, and has the capacity then to negotiate with private sector for partly delivering on those priorities, right? And can bring efficiency to the use of resources by negotiating contracts with private sector in a really capable way, right? So then you get into a really good momentum where you can say to your Minister of Finance, the resources you've given us, we've used in a good way. These are linked to very clear results, and these are our results. And how do we further build on that, right? And so that longer-term domestic financing comes from a trust and a confidence of linking well-used resources to results that we're after. And then maybe then to come to your question, right? Because I can see a world in which the partners can play a really important role in ensuring, because it's so context-specific, right? And ensuring that we bring out those problems that we see, can we help facilitate finding solutions for that, right? And we oftentimes engage with investors that are interested in having an impact and knowing that our money bring social impact and improve the lives of people? And how do we bring our local knowledge on what the problems are to those solutions, right? And we started to work on 2 or 3 products that we think can be larger scale, et cetera, and can then be supportive to that country agenda that we're after.
Yeah, and I do want to get others in the room into this discussion soon, because I want you to push us too on what you're seeing happening at the country level or at your own institutional level. And we'll do that in just a moment. But I do want to come back briefly, if I can, to Ag and say, you know, you've been here at GBC Health. You're meeting with lots of corporates at the finance side and the project implementation side, as well as government. Are you seeing any traction that makes you say this is a good example of what we can be doing more of? Are you seeing examples you think we should be doubling down on?
I think that the fact that conversations like this are taking place repeatedly at the country level, at the regional level, and at the global level is fundamentally important, okay? If you take Africa, you don't have one situation to fix. You have 54 country situations to fix, each with different dynamics, each with different issues, and each at different levels of, if you like, solving the problem, okay? So proximity is critical. So I honestly don't think that any product designed outside of Nigeria is going to work for Nigeria. I don't think that any product designed outside of Rwanda is going to work for Rwanda. It just won't happen. Now, we could have templates, we could have generic theoretical underpinnings for products, okay? But then you've got to go to the country situation and fix it. And I'll just give you a simple example. So I have a friend whose father is quite wealthy, 78, and has had health challenges for a while. And the last I heard about 4 months ago was that he was coming through chemo and he was doing okay. And he's gone through, I don't want to go abroad anymore for treatment. I'll sort myself out in Nigeria. And then my friend sends me a message and says, my dad passed away. And I get on the phone and I say, but he was getting better. And I said, what happened, you know? And he said he had an accident. I said, what? An accident? Why was he, you know, where, you know? And apparently, in the Midwest of Nigeria, okay, the only hospital whose equipment was working for 2 months was, he had to drive 2 hours for it. Now, it's not to say you don't have equipment in Benin City where he is. It just doesn't work. So, you know, if you take treatment of NCDs, I think that if you put this room together, took them to Nigeria, okay, with the brain power here and the experiences, okay, they would probably be able to come up with a value chain using local resources and already sunk investments that works, okay? The problem is, I think the greatest problem for at least Africa is beyond the financing, the more important thing of knowledge, skills, and values is what is missing.
Yeah, and that might be one reason when you look at the organizations that are involved in the emblematic deals that exist so far, because it's not that many, they are often the same organizations over and over. And you see USAID and OPIC, you see MSD from others, Merck from others, you see many of the same groups. And ideally, if we're going to get to this 2.0 era, you would have more of an open market where there's lots of opportunity for many organizations to be a part of this. But if you don't have that local knowledge, if you don't have people on the ground, and if you don't have that country context, it's very hard to enter into this space. So I do want to come to all of you, and I'm hoping you'll push us a little bit or give us an example that you've seen. I think, do we have microphones to go around? We do. Are there anybody who's ready to jump into the discussion? Over on this side, I've got a couple here. I see a colleague from MREF, but just tell us your name and organization if you would.
Thank you. My name is Beatrice Katumia. I work as the Universal Health Coverage Lead for AMREF Enterprise, which is a social impact business. So thank you to the panel. I think the discussion has been very great. I have a question about, and maybe something to consider. Are we involving the public, especially in Africa, enough in innovating around these models for health financing? So for example, when we think about bonds, is it far-fetched to think that we should encourage the public to invest in bonds? The same way in Kenya we had the mobile bond for infrastructure development. So I think that's something we need to consider as far as resource mobilization domestically.
It's a great question. Maybe you can pass the microphone right next to you. We'll take a few.
My name is Warogoro from Dalberg, also from Kenya. My question is, are there examples of where innovative financing has worked in more advanced healthcare systems? Across the panel today, I've heard about MCH, and I've also heard a lot about more developing places, but it's also the place where people have least access to the capital to do health. So these people with the least access to capital are the ones that private financing is being considered introduction, but are there any examples in a more developed UHC system that could be adapted? Because if it hasn't worked where UHC has worked, why would it work here? Why is the discussion a lot about the developing countries being the ones to use private financing if no one else is using it? As far as I know, so I'm happy to be educated.
Great question. And there's one all the way in the back corner there. We can pass the microphone.
Yeah, thank you very much. My name is Oluwole Smile from Center for Economics and Development in Nigeria. In Abuja. My question goes to Iboje, and I want to ask basically on two things. Number one is the private sector participation, especially in northern Nigeria. We all know that the northern Nigeria's high level of poverty rate, and we've been privileged to carry out some fiscal space analysis across all the geopolitical zones in northern Nigeria, and also costed their strategic plan. And when you compare the fiscal space available with the costed plan, you discover that there's a huge funding gap, as he earlier said. I mean, the fiscal space available could not even fund up to 20% of what they have costed. And as you said, that the private sector have to come in. So how do you think private sector, mostly that are somehow profit-oriented, can really come in an environment with high level of poverty rate? That is the first question. The second question is basically...
That wasn't for you, but go ahead. I don't know who that was for.
Okay.
Just keep it quick.
Okay, yeah.
I don't have that power here. I wish I had a button I could press, but I don't.
So the second question basically is, from my experience, being the technical lead on national health account in Nigeria, supporting Federal Ministry of Health, we've realized that 87% of the spending of primary healthcare services actually took place at non-primary healthcare facilities. Most of them took place at secondary and tertiary, as well as the chemists, the roadside vendors. So how do we ensure that we can condition the health system and to ensure primary healthcare facilities happen to be the point of entry into the health system? How do we push almost 87% of the health spending down from the tertiary and secondary towards the PHC, and also from the roadside towards trade? Realizing the fiscal federalism, I quite agree with you on contextualities and basically the heterogeneity of the Nigerian system. Thank you.
Thank you. So lots of interesting interventions there. Maybe we could just start with this one from MREF. It's a good question. Why can't you have countries, if it's such a good investment, if it's so tied to the overall economy, if there is a need to increase domestic resource mobilization, why can't you just have publics invest in public bonds to support health? Any thoughts about this, Monique or others? Or go ahead, Sid.
I think it's absolutely doable. In fact, we did some calculations. Innovative approaches need innovative financing too. And for example, in Kenya, we did an exercise to look at what a $1 or 100 shilling contribution through an M-Pesa transaction, which is over 10,000 shillings or $100, could do in terms of creating velocity of financing. What we found, we could actually raise close to $5 million a day, which is $1.8 billion a year, which would finance the entire NHIF or the National Health Insurance Fund, and would actually put an army of community health workers on the ground who are getting $1 a day. I mean, a child in Mandera who's 17 years old is equally competent to provide all the healthcare services from immunization to basic diagnostics, because you're connected through telemedicine, and you can actually have a doctor in Nairobi providing those services, looking at a group of But we have to rethink our models, Raj. Our perception of health is a facility with a doctor or a nurse sitting there. What Philips and all that are doing is rearranging that model. You actually have a midwife with a backpack who can go to 10 homes, help in the delivery, and the moment there's a complication, she's able to dial into a doctor. You overcome infrastructure challenges by the use of drones. Use a drone out of a health facility which can go reach a woman with blood and drugs. But it'll have to be a complete revolutionary thinking. And let me tell you, the amount of money that is being looked at for UHC is more towards the curative side rather than the preventative side. The preventative side is basic. You get people covered with measles immunization, you won't have an outbreak of measles in New York, as simple as that. And that is where we have to reinforce ourselves on the preventative side, and that's where the money is going to be. The investments will be, return of investment will be on volume, not on cost.
Well, it gets to our colleague from Nigeria's point about how much money is going to tertiary and secondary care instead of to primary. But I wonder, just sticking on this theme, and it connects with the point from Dahlberg here, are these contexts so different? So does it only make sense to go to Publix and try to raise money for bonds in the poorest countries in the world? What's actually worked in Europe or more advanced economies that we can learn from? Are there any thoughts from the panel on that, Monique?
So, sorry, I think the World Bank Treasury is actually thinking in the direction that you're thinking and having these conversations with various countries on country level. And so I think it's interesting you raise it, and it's definitely one of the next frontiers. But to come to your question on, I'm thinking about the blended financing. And for us to reach UHC, we need public financing. But we need to work with private financing in a way where we can use strategically small amounts of public financing to steer private investments into a certain direction. And so if we are interested in reaching certain populations or addressing certain weaknesses in the health system, which has been done in European countries, for example, we can use grant funding to help steer private investments in the right direction. And for us, that is our next frontier. We are working with the IFC, the private sector arm of the World Bank, to really use that as a tool. What are some of the problems that we're seeing in the countries that we're working on, where we can have private investments, and we use the GFF grant funding to steer those private investments to help address those problems. For example, the quality of C-sections in hospitals, laboratory services in the most remote areas, the supply chain. And these are oftentimes smaller private investments, and so they're higher risk for private investments to come in, and we can help modify and lower that risk by bringing in some grant funding then to ensure that those deals that really will help poor people are also coming to closure, and we can make those deals.
Any other thoughts on that point about the models we can look to from other countries? Go ahead.
Well, ultimately, let's not kid ourselves. The public always pays for health one way or the other. And it's either going to be a market form of payment, or it's going to be, just a fiscal, government tax, approach. Now, the thing about it is that in African countries, the economies are not significantly organized. So it's not about the size of the economy. It's about, like, say, if you look at the tax, the tax bracket. If you could get literally hundreds of millions of Africans paying tax for health, all right, you would mobilize billions of dollars within Africa for health. But then why would I accept a tax when there are no hospitals around me and I've lost trust in the capacity of the health system to deliver health? Now, so fundamentally, things have to be redesigned, okay? And beyond the technology of how health is made to work in Africa, there's that fundamental issue of trust. Do you trust those and when I say that, I'm not just talking about the public sector. I'm also talking about the private sector, okay? So, I listened to your comments, and I totally agree that new approaches are required, okay? I think the problem is this. If you look at the interventions They are going to either happen at scale, which require large health providers, and you don't have local large health providers. They're all multinationals. Or you're going to have some SME type of approach, to doing it, okay? Unfortunately, the large health providers are not proximate. The decision-making is here. It's not there, okay? And so something has to be done about that. Now, with respect to the SME type of approach, okay, we have talented health workers moving out of Africa because the value chain doesn't work, okay? So it's not that we don't produce great doctors and health practitioners, but they're leaving in droves, okay? So that also has to be addressed, I think fundamentally 2.0 is going to be a function of new thinking, new leadership, and a stronger commitment to doing things, with impact.
You're underlining a point that I've heard from many, including yourself, which is it's really not about the money, it's not about the technology, it's actually this mindset shift that is the critical thing. But that's also kind of a frustrating point, even though it might be very well true, because we think, how do we get there faster than we are right now? How do we push this a little bit more quickly? You're right, the public ultimately always pays, there's no doubt, but currently pays in maybe the most regressive ways in the world, right? And the poorest people pay the largest percentage of their assets and income, and as a result, 100 million people go into bankruptcy and go into poverty every year. So it's really, you're absolutely right, the money is there in a sense, it's the organization of that money in a way that's equitable and sustainable. That is what is ultimately missing. I wonder, Catherine, and I do want to come back for one more round of questions, but maybe we can talk OPIC for a second. I hinted at this in the beginning, that we're in just the final days or weeks or months of using the name OPIC even, because as I think many of you may know, the US government, it has pushed forward a plan to create a new agency. It's actually passed the US Congress, and that agency is the Development Finance Corporation. It's something that for many years both parties have been talking about doing, and now it looks like it's happening. We had a hearing for the nominee to be the new head of the agency just a few days ago. So it's really moving forward. Can you give us a context for health in this new DFC? Again, I know it doesn't exist yet. Monique gave us a little insight in her organization talking about these bonds. What insight can you give us into the new DFC in health?
Yeah, this is a private conversation, right?
Yes, only a few million people are listening.
Maybe relating back to one of the points that you made, that we have the same usual suspects around the table, and you listed OPIC as one of those. I highly disagree with that. I don't think people in the healthcare think about OPIC as a potential financing partner because we don't have healthcare expertise, which is really remarkable. We're a development finance institution, and as we think about these finance ministers that haven't bought into the idea that a healthy economy is related to healthy citizens, we hadn't bought into that at OPIC as well. And so as we look to launch the new DFC, part of this really new partnership that we had with Merck has changed a lot of the way that we're thinking at OPIC. And as we launch the DFC, we are going to be focusing on healthcare as a core piece of expertise that we need to build out so that we have people in finance that understand healthcare. There's so much innovation and tech that is changing this industry all the time. You can't underwrite every deal coming from scratch. So DFC will have a very strong healthcare focus, and I'm excited about that.
I know it's early, but tell us a little bit more about this model of what you're doing with Merck and what the applicability might be to others.
So the initial partnership with Merck, again, is based on this idea of radical collaboration, that we can bring together an expertise for maternal health, along with really expertise, but also grant financing from USAID, and development finance from OPIC, along with traditional commercial investors in Credit Suisse. And the idea is that together we can build a pipeline, identify and change when we're looking at enterprises, social enterprises that have spent their time and energy learning how to apply for the next grant, and that's how they're thinking about getting their next round of financing, which is not financing at all, it's just more grants. We're using those grants to ask them to think about what do you need to do to change your enterprise to prepare you for actual debt financing or scaling capital. And that's a different mindset for some of these enterprises. So it's really been a fascinating process to identify which social enterprises we feel have the development outcomes that we all believe in? And then B, how can we help shift that enterprise to be both scalable and sustainable from a private sector perspective?
Thank you for that. I do want to come back to all of you and see, I see a hand all the way back there. Maybe we can get the mics there and a couple here. We'll take the two that are there first and then two over here. And again, just say your name and organization if you would.
Great, thank you so much. Good morning. This is a great panel and I'm glad to be here. Melissa West from Village Reach. We work on healthcare delivery systems for the hardest to reach. One of the issues that we see most is that even if capital is available at the national level, it's not reaching subnational levels. So I was wondering if you could talk a little bit about how you're supporting the governments at the subnational level to first get the financing, then to be able to manage it well for health. Thank you.
Great question, and we got another one just a couple rows in front.
Hi, Sue Henschel from City Cancer Challenge. So we work with cities around the world to support improvement of cancer services and infrastructure. I wanted to ask the panel, I think Catherine just touched on it then, but you've talked about the gap in knowledge and experience from the finance sector, but our experience is when you take the conversation of finance to our health professionals, that is also an enormous knowledge gap around informing, educating, building the skills and knowledge for the health professional community to create investable opportunities. And we're seeing an enormous gap in knowledge between the two. So if you had any guidance on how to bridge that gap and what experience have you had in making that work?
Great, thank you. And then these two here, and I know there's more hands than that. Sorry, right in front. One row up, yeah, thank you.
Hi, Pam Bolton. I work for Tech Care for All, which is a social impact business in digital health dedicated to accelerating UHC, involved in also telemedicine and booking platforms for training. So my question is a very simple one. You talked about the absolutely critical nature of universal health coverage, and Sid, you mentioned employer-based insurance in the case of Singapore. I would like to hear opinions on what you see as the proper role for employer-based insurance programs. I mean, clearly government coverage is essential, but companies and private sector can contribute in that way. So I'd just like to hear some opinions on that.
Thank you.
Thank you to the great panel. It's been very informative. I'm Adeze Ore, a family physician and public health specialist with the Federal Ministry of Health in Nigeria. And it's funny because over the weekend, I was one of the judges for a hackathon. And this year's hackathon was focused on maternal mortality, maternal health. And the winning team proposed a solution that combined addressing maternal health with environmental pollution. And I mean, it blew everyone away and they won the hackathon. So my question is, what do you think are the potentials for private sector working with the public sector to strengthen health services, looking at WASH, looking at water, sanitation, hygiene, in addition to some of the preventive health education, immunization services? Because we see a lot of the financing, the partnerships that are being proposed to government focusing on disease areas, so malaria, HIV, and AIDS. I actually led a 3-state project with PEPFAR on HIV and AIDS for about 5 years. So a lot of these offers come, but they're directed and focused at certain areas, leaving 80% of the communities not knowing vital information on basic hygiene, environmental sanitation and things like that. So what do you think are the potentials for partnering to strengthen hygiene and environmental sanitation, safe water at the community level, in addition to providing quality health services? Thank you.
Let's start with that. Thank you for those great questions. And can I go to you on this one, Monique, first? Because there's a lot of financing in the infrastructure space. So in some ways, maybe that is a portal into generating better health outcomes. What do you think?
Yeah. Great, thank you for all the questions, really inspiring. I actually want to link it to the question of decentralization. because there's a tremendous amount of innovation going on in financing of frontline services. And so we haven't talked much about it, so thanks for raising it. So there are various ways in which we can push resources to the front lines and provide incentives for governments to ensure that on the decentralized level, resources are arriving where they need to go. And we, for example, in Kenya, do that by working directly with the county and matching the grant funding we have. If they allocate more funding of their overall budget to health, we match that with grant funding, right? We do it by linking financing to results and contracting facilities directly, and paying for the results that they deliver. And we also do it by providing grants directly to communities because of their knowledge and understanding, and empowering them to find solutions for their local. And so that really relates to your question on the health facilities. I don't know if people are familiar. The White Women Alliance did a fantastic survey. I mean, they interviewed millions of women, and one of the top 3 issues was we want clean water when we deliver in facilities, right? And so it's 2019, right? And we're having a conversation in which women say we want clean water when we give birth, right? And so, I mean, I have to say, I was just so touched by the simplicity of it and our inability to deliver that, right? And so we are building in all of our programs that directly finance facilities, clean water into the way we incentivize and finance and motivate staff to ensure that, at least in facilities that we support in the 36 GFF countries, this is something that we will be addressing. And similarly for community. I mean, we've known for a very long time how much clean water and sanitation impacts health results, right? And so we need to use the financing and the tools we have to ensure that we achieve that.
And there's a big shift toward decentralization of water services and sanitation as well, which could be aligned with this idea of getting more funding right to the front line. Most people here know at the county level, in the state level, in Nigeria and Kenya, there's a lot of authority and a lot of budget. Go ahead, Sid.
Again, Singapore makes a good model. High intensity of cholera, very, very high malaria, they cleaned it out because there was political will, and the primacy of political will should not be undervalued. When a head of state, for example, in Kenya, has said his legacy will be defined by universal health coverage and he wants to achieve it, universal health coverage does not mean let the secondary and tertiary care be market forces. Let's invest on the preventative side. Let's invest in those simple things like clean water, like prevention of vector-borne diseases, like ensuring that, there are behavioral changes. I mean, what is going to bankrupt African insurance systems like in India is going to be diabetes. That in the next 4 to 5 years, that's the window. Today, sub-Saharan Africa is reeling under debt, and we are talking about more bonds. They'll have to be looking back and paying for all of this all over again. We need to find a completely different instrument of financing it, and that is why you want more and more private sector. And let me tell you, there is a demographic transition happening in Africa. 2.3 billion people by 2050, 850 million young people by 2050. It's an enormous market. But that market will be in volume and not by cost. And that's where the opportunity for the private sector is. Smart investors will look at that opportunity rather than, a company which, I don't want to name companies here, but a company which is producing insulins, then you've got a supply and demand issue, and suddenly all these costs will go up. So we'll have to rethink the way we actually finance health, and that will come when you get more and more public-private partnership that looks at the opportunity of scale, and there's more disposable income. Therefore, the private sector actually benefits when there's more disposable income simply because preventative health has worked.
Maybe you want to get in on this topic of subnational, and perhaps there's a connection to the idea of employer-based plans. We haven't gotten into that much, and maybe it's a bit outside the scope of what we're here to talk about, but let's see if you have a take.
The reason why subnational and primary healthcare in Africa is so fractious is that it appears to be the highest risk point in the chain in terms of making it market-based, okay? And it needs to be de-risked. So I like to think about the way to de-risk at scale on the ground is behavioral. And you look for the things that people do or use, right, and are tied to, and use that as a means of influencing the behavior that de-risks the environment. And the most potent tool, actually, for influencing behavior in Africa is the mobile phone. And the mobile phone, okay? And, I mean, now this is 2020, hindsight, but honestly speaking, with the licenses for a mobile phone, one of the cheapest ways a country can influence behavior is to make conditional to the license holder for the, whatever technology you're using, okay? Certain amounts of daily airtime by which I can send messages, I can influence behavior, and I can, make people do things, okay? And for example, one way I could do it is that if you don't go to hospital, your phone goes off. Yeah. It's that simple. It'll work. It's that simple. The phone can do it. I mean, it's just no big deal. It can be done with, and there's no extra, already the transponders are in this, so all we do is map where the hospitals are. It's not telematics, and so the technology is there, okay?
Somewhere for health behavior.
Right. And, but you see, it may be out of the box, all right? But in truth, if you think about the fact that already you have insurance companies that literally do that with your car and so on, it's not that far-fetched. And remember, Africa's problems, will require unique African solutions, okay? Now, there is also one big reality, which is that based on the various legal systems and, constitutional provisions, primary health care in some countries is something that the federal government has to do, okay, whilst, it's meant to take place at the local level. So that has to be fixed. I think that the private sector is a powerful, from an employer standpoint, but unfortunately, the private sector tends to crowd in certain economic zones, okay? So for example, there's very limited employer type of scale activity in the north of Nigeria. So if you're using the private sector to, influence employee behavior in the north, yes, you will get numbers, but as a percentage of the total, population, it's very low.
I think that was the point our colleague from the think tank in Nigeria was making.
But then, of course, there's also faith-based, and you can use other communities, not necessarily employers, so you could use churches, you could use other faith communities, and so on to do great things. There is the Emir of Kano in the north of Nigeria has done some pretty fascinating things around maternal and child health care, and actually come up with customary rules as to what fathers must do and so on, okay? And trying to codify them. So that's also something that we can look at. Political will.
Catherine, I wonder if we can get your take, and then we'll have a very quick wrap up here because we want to hear from Marianne. But get your take on the financing question here. Sid talked about maybe there's too much debt already in the system. Perhaps that's true in some instances, but what's your take on this question of where the money should come from and how we should finance health?
Maybe I can relate it back to WASH, where we're putting hundreds of millions of dollars towards WASH and access to clean water, and we're doing it through the private sector. We're not issuing public sector debt at all. We're raising blended finance mechanisms with family offices, through our own issuance of what we call COPs. So maybe there is a lot of too much public debt, but I think there's huge opportunity for us to mobilize private sector capital toward even the most difficult to reach places.
Well, it gets back to this point about the efficiency of the system. In the end, there's no choice in this, right? People need access to healthcare. So if we can make the system more efficient and we need financing to do it, it makes sense to do. Now, a final tweetable thought from each of you, because I do want to make sure we have time for Marianne. Maybe we'll start with you, Catherine, and come in this direction. Can you leave us with one thought that comes to mind now as we wrap up this and think of the 2.0 era in the future of financing?
Optimism for healthcare expertise in the finance sector.
Health is wealth, and there's a whole lot of wealth in health.
I like it.
Wow, sets the bar really high.
Yeah, really.
Fearlessly and courageously fight for the primacy of sexual reproductive health and rights.
Measure your results.
Yeah, none of this works if we don't measure. We didn't talk that much about data, but you're absolutely right. Please join me in giving a big, warm round of applause for this great panel. And please remain with us on stage as we welcome Marianne to join us to give us some closing thoughts.
So thank you so much. I think we can all say that this was not another Groundhog Day. Thank you for sharing. I think the actual significant and substantial amount of progress that has been made in the last year. We are nowhere near where we need to go, but through the themes that have been raised here about how there really is a gap between the health sector and the financing sector, how we talk about things, how we measure things, how we think about things, and whether we trust each other. And so these are the types of conversations that need to happen and actually need to be followed through into actionable recommendations so that we continue to make progress and we can close that gap. The other thing I want to say about that gap is that gap requires sweat equity. And all of you here have put in enormous amounts of sweat equity to figure out how we close that gap. The last thing I want to say is the call to action. We've talked about it, Katie. You've talked about these radical collaborations and how they're catalyzed, how they're powered. All of our strange bedfellows. There's a room we have out there waiting for all of you to make this next generation of collaborations and partnerships so we can continue to power for progress. So thank you so much. We need to learn from each other. Go forth and want to see next year what the collaborations that are created from this conversation and from all of the folks in this room create. Thank you, Raj.
Thank you, Marianne. And to those of you joining us online from all over the world, thank you. This conversation will continue. It's a great way to kick off the UHC Pavilion Day. Thanks again to all of you for being here. I look forward to having conversations outside. Thanks.
Thank you.